The last session we had some problem with the internet connectivity. So we'll start from the point where the interruption had occurred. The about the bandha, in case of the bhagna, the bandage has to be changed once in 7 days in case of cold seasons, and once in 5 days in moderate season, and once in 3 days in hot seasons. The reasons are simple, because Sushruta had used the barks of the tree for the bandage. Barks of the tree would be changing their shape and dry up. So hence, depending upon the seasonal factors, the bandage had to be changed. Moreover, there is another advantage of the changing of the bandage. The changing of the bandage would reduce many of those drawbacks which could be produced due to a rigid splint like a POP splint. As we know, with the POP splint, when it is applied, it has some drawbacks. The drawbacks are, there could be, if there is an edema before you apply the POP splint, that in due course of time, as the edema reduces and the POP doesn't change the shape accordingly, there would be some undue movement which can affect the healing. Or the other way, if there is an edema formed after the immobilization, then there could be a compression and a wound can, or necrosis of the tissue can happen. If the patient has an open wound with the POP bandage, it's difficult to maintain the wound care or to have the wound care. So usually in such conditions we have a window dissected in the POP which can reduce the strength of the POP. So that's the other drawback. POP also is difficult to maintain the hygiene, and when you use the POP, two joints have to be immobilized, and because of that, due course of time, there could be either sudex atrophy or there could be adhesions formed. The rigidity of the joints which occur later on also could be the other complications. Stiffness or osteoporosis also could occur due to that disuse or having this immobilization for a quite a long period. Whereas that interrupted movement which can occur during the changing once in a week or 3 days can reduce many of these complications. Like if there is an edema, that edema can be managed every time you change the bandage, or the other way, wound care of course also is quite easy. At the same time, current generation of orthopedicians, or the latest knowledge of the orthopedics also has identified this issue, and now the trend is to prefer a dynamic splinting than really the POP splint. Some few years back, some 10 or 15 years back, those fractures which were managed only with the POP splint now have some other alternative. The alternatives are what we call as dynamic splinting, where either a fiberglass material or some other elastic material or materials with certain modifications like the springs and rods, they are available, and these are becoming popular, which can reduce many of those issues related to that rigid POP splint. That principle of changing the bandage at regular intervals, maybe once in a week or 3 days, as mentioned by Sushruta. And the basic idea of using a dynamic splinting is the same. The only difference is about the technology. Now you have a more sophisticated, convenient technology, whereas Sushruta preferred to change the bandage once in a week. Though that principle has to be appreciated. Then, as far as the grip of the bandha is concerned, now in Sushruta's period, the bandage had to be tied with a bandage, this knot, and that knot had to be placed in a moderate manner. That grip of the bandage, in case of the Vradabandha, we have discussed like the Gadha, Shichila, and Samabandha. Variation depending upon the location of the body, of the anatomical area of the body, as well as the season and the condition of the wound. Whereas in case of a bandage, these bandage due to for the plaster condition, these fracture conditions, you are not going to change that this grip of the bandage. It has to be always a samabandha, moderate bandha. Reason is simple. तत्र अतिशिथिलं मध्ये सन्धिस्थैर्यं न जायते. If it is a shithila bandha, there will not be immobilization, proper immobilization. The bones may move around. And gadhenapi togadinam shoko rupaka evacha. If you say gadabandha, there can be edema or even the compartment syndrome like complications. Tasmat sadharanam bandham bhagnesham santidadvidah. Now, after putting the bandage and this splinting, the wound had to be treated with the kashaya, or fracture had to be treated with the kashayas, pouring some liquids with an idea of reducing the pain is again a unique idea of Sushuddha. Negrodhadi kashayam to sushitam parishedane, panchamuli vakum to kshiram kuryat sabedale. Either necrodhadi kashaya or panchamuli kshira kashaya has to be poured over the area so that the pain would be reduced. And it also promotes the healing. Then Sukhostam Upacharyam Chakratailam Janata. Chakrataila is another of the technique or another of the medicines which was used in those days for reducing the pain. Chakrataila is one of the measures used for reducing the pain, and in many other conditions also is mentioned. Chakrataila is either there are two forms of Chakrataila, two definitions of the Chakrataila. One is in those days the oil was extracted with the wooden mills, and those wooden mills after their utility, that wood piece would be broken down into smaller pieces, and then it's boiled in water, and then the oil which was absorbed by the wood would be coming out, floating over the water, and that had to be collected, and that's a Chakrataila. This is one of the unique technique of microfining the molecules. Now also in the current pharmacology also, that kind of a technique of microfining the material molecules to facilitate the absorption are practiced in many conditions. But now you use some sophisticated technology, whereas Sushruta's technology was somewhat primitive. So that's one. Chakrataila is either it's the oil extracted from the old worn out wooden pieces of the mill, or Chakrataila also is defined as the Sadhya Nishpedita Taila. The taila or oil which is just being extracted out, which is still warm. As the mill is moving around, it becomes warm, and that fresh oil without any fat changes or degrading changes of the fat, that also is considered as a Chakrataila. But practically to make use of that now in the present situation is quite difficult. The reason is simple: you do not have a wooden mill now, and to think of a fresh oil to be poured over the area of the wound fracture also looks impractical now. Anyway, but the idea of making use of a microfine molecule or such a fresh fat without any oxidation or changes, degradation changes as such, for the benefit. These are the two important pharmacological concepts otherwise of Sushruta. Anyway, Vibhajya Kalam Dosham Cha Dosham Naushad Sayutam Parishekam Pradeham Cha Vidadyartal Shilam Yamata. Depending upon the dosha, dusha and the season, you have to, maybe you may select the drugs. It need not be only Necrodhani Kashaya or Panchamukta, it could be any other drug which could be selected, but it should be cold as such. Now, another of the dietary suggestion given by Sushruta is the Gristik Shira. Gristik Shiram Sasarpishkam Mathurosham Saditam Shitalam Lakshayayipam Pradar Bhagnaha Pivennaraha. Gristik Shira is another of the dietary supplement given or suggested in case of fracture management, and that too the Kshira milk is to be processed with ghee as well as other Madhuroshadas, and Laksha, which is a Sandhana, there in the Sandhana Kara Aushadhi, has to be used. Now, Gristi is another unique idea. Gristi is defined as either two definitions. Dhallana has defined it as a Prathama Prasuta Gau, the cow which has delivered for the first time, the first delivery. Or the other definition of the Gristi is the Sadhya Prasuta Gau, the immediately after the delivery. Now, the milk which is extracted immediately after delivery, which we call as a colostrum, and even in human beings as well as in bovine, that in the cows also, the colostrum has extraordinarily rich protein as well as rich immunoglobulins, which will be protecting the body, and this has a high nourishment value. And the nourishment value of nutrient value of colostrum and the routine milk in case of the cows is now known, you have documented this data of these, like the solid, all that components, and particularly the important issue is about the content of immunoglobulins, the globulins which will help in modifying the total reaction of the body, as well as the nourishment produced due to the proteins also is quite significantly different in comparatively content to this regular milk as well as the cholesterol. And the other way, the other theory is like if it is a prasama prasuta, the first delivery, this also is true when the lactation starts in human beings as well as in animals. The first episode of the lactation would have more protein and fat containing milk, whereas consequent lactations, like consequent lactations in the sense second birth, third birth, and so on, the protein content and the fat content becomes lesser. That's also known as such. So that's one of the basic physiological principles adopted for maintaining the nourishment of a fractured patient as such. Then the next is Savarnasya Bhagnasya Vranam Sarpir Madhuktarehi Pratisarya Kashayistu Shesham Bhagnamadachareta. If it is a compound fracture with a wound over there, now in the compound fracture there could be two possibilities, where there is a wound but the bone is not projected out, or the other way where the bone has projected out. In those conditions where the bone is projected out through the wound, the approach to the treatment is something different, which we will come across later on. So Sudha refers to that issue also in the later period. So when we come to that sloka, I will refer to that part. Whereas if it is the other way, that the wound is not having that bone projected out, in that condition, the first approach would be to treat the wound. You have to clean the wound, ensure that there is a hemostasis, and you have to apply the drugs which would promote the healing of the wound, and then you have to manage the fracture with the splinting. So before you splint, the wound care, soft tissue wound injuries have to be taken care of, and that's one of the basic principles in every case of fracture. Now the next is about the total duration of the union which is required. Now to understand that, you have to have some basic idea of the changes which occur during the fracture healing. The fracture healing and the changes which occur in the body immediately after fracture is the first few days there would be an inflammatory phase, a phase where there could be mild inflammation in the area, and it occurs within 1 week as such. Then there is a reparative phase. The next this phase where there will be a healing. So what happens is once there is a fracture, the gap of the fracture will be filled by a blood clot, and that blood clot will be gradually having that inflammatory phase where the blood cells will be replaced by fibrocartilaginous tissue from the exterior, and this is taken in 1 week. Now during this phase, it is absolutely important that the size of the blood clot, the gap between the two bones have to be minimum, and the size of the blood clot will be the decisive factor which decides about the time taken for the next stage. So if the size of the blood clot is lesser, that clot which bridges the gap between the two ends of the bone, then the time taken for the union would be shorter. If the gap is more, then the time taken could be more. At the same time, there should not be any further movement between the two, because if there is a further movement, this clot will be broken, and the breaking of the clot would result in more complications. And hence, the basic principle of the fracture treatment is you have to keep the reduction, the space between the two ends of the fractured bones should be kept as minimum. That's what we call as a process of reduction, or rather it's also an effort to maintain the anatomical integrity. The shape of the bone has to be retained, and then to prevent the clot from breaking down, it has to be immobilized. The movement should be reduced. Then gradually there would be a situation where the fibrocartilaginous tissue would be formed and developed over the clot, and at one stage the gap between the bones is filled by a mass of the cartilaginous tissue as well as the calcium which is deposited there, but it doesn't have the same configuration of the normal bone, and that phase is called as the union phase. Now once the union has occurred, The mechanical strength of the bone may have regained, though the bone is not normal. So once that union has occurred, there is no need to go for further immobilization. The patient can bear the weight of the bone, and the whole phase, the time taken for the next phase where that callus is replaced by the normal bone, it takes a longer time for minimum, or it could be like 3 months, 6 months, or even beyond that. Time taken for the union, as per the current golden rules of the orthopedics, the minimum time taken for that is 3 weeks. 3 weeks, if there are no other inhibitory factors and if there is no other extraordinary factors, the union would occur by 3 weeks. And once that union has occurred, that immobilization can be avoided. Patient may be able to move about and make use of the bone functionally, but structurally it takes a longer time. Till then, the healed fracture, it takes about a minimum of 6 months as such. And the general rules are, the simple fractures are classified as either spiral, oblique, or transverse, and a fracture with multi-fragments is having complications where the piece of the bone would be having avascular entity and the blood clot could be affected, and hence the healing could be delayed, and that needs to be taken care of. That any extra piece of the bone which is in between, which doesn't have a vascularity, that will be preventing the healing. Wedge fractures, which are spiral or low energy fractures, there is not much of a gap. There will be always a contact, and hence there the union would be faster, and many times that duration of the immobilization can be even lesser than 3 weeks. A multifragmentary fracture is also a segmental fracture, which is where there is no contact between the proximal and fragment ends. It cannot be managed with just simple management as such of immobilization. Then you need to have a direct intervention. Now, as far as this wound is concerned, the compound fracture is concerned. Compound fractures, as Sushil has mentioned, Sauranabhagna, Sushil has mentioned with one sentence, Sauranabhagna. Now, from the current point of view, you have to grade that Sauranabhagna depending upon the issues related to the complications or the tissue injury, amount of the tissue injury. And the general classification of a compound fracture or a Sauranabhagna is of the three types: type 1, type 2, type 3. Type 1 is when the wound is smaller than 1 centimeter, clean, and generally caused by a fractured fragment that pierces the skin from inside out, from the bone is trying to project through the area, and this is usually due to a low energy injury. Low energy injury like a simple fall or somebody hitting simply without any machinery or without high velocity injuries. Type 2 is where the wound is longer than 1 centimeter and there is not much contamination and without major soft tissue damage, not significant as such, and that's the type 2. Type 3 is when the wound is longer than 1 centimeter and there is a significant soft tissue disruption, and the mechanism involves high energy trauma which results in a significant unstable fracture, and there could be a contamination, high contamination over there. Further, it is classified like the 2A is classified as a wound has sufficient healthy soft tissues to cover the bone without the need for local distant flap or coverage. So if the bone is projecting out, it can be covered with the tissues, then it's called as 2A. If the disruption is such that and the bone cannot be covered completely and the wound is contaminated, then the debridement is necessary. Such condition is called as 3B, and 3C is open fracture with the arterial or neurological injury that requires repair of the bone with more detailed approach, and the more detailed approach is that avascular bone has to be either removed and then the gap has to be filled with a bone graft. So that's the condition called as the third C. So now the approach to the treatment of fracture, though the principle is same, you need to take care of the wound, you need to take care of the immobilization, you need to take care of the union of the fracture. The details are more, whereas Sushil has maintained this in one sentence. Now, based upon the same principles of the healing, we have to understand the time duration for the union of the fracture. Sushruta has described Prathame Vaisitvam Bhagnam Sukaramatishet Alpadosha Sijantustu Kaleja Shishiratmake Prathame Vaisitvam Asat Sandhi Stiro Veda Madhyame Digunat Kala Uttare Trigunat Sundraha. Now, current orthopedic discipline says that no union or no fracture would unite before 3 weeks. 3 weeks is considered as the minimum duration for the union of a fracture, whereas Sushruta has considered 1 month. Prathame basic masa, the earliest possible union, usually which occurs in the younger age, would be by 1 month, and of course it can be enhanced because of the other factors. Now, the golden rules of the current orthopedics would define these variation in the duration of the union, which is necessary for planning the immobilization, as upper limb fractures without complications would be uniting in a period not less than 3 weeks, whereas lower limb fractures, because they carry more weight, they may require double the time, 6 weeks. This is what the current would say, and the current guideline also says, like, if there is in the old age, it may take another 2 extra weeks in the older age, whereas Sushruta has defined slightly a variant where he has not mentioned about the upper limb, lower limb variations. Instead, it's only about the age factor which is considered. In the Madhyame Yuganata, in the Madhyama ways, middle age, it is about 2 times, that's minimum 2 months. Uttare Tribunata, in the later half, later 1/3 of the age, like the old age, it's considered as 3 months. And hence, Sushruta has considered Prasama Vaisitvam Bhagnam Sukaramakshet. In the younger age, children, the fracture unites early, and hence it is considered Sukara, or easy to manage. Now, there is a bit of apparent controversy. The apparent controversy is in the Bhagna Nidana, when Sushruta has mentioned about the Kritshasadhi Bhagna. Young age is considered as a age period where it's a Kritshasadhi. Old and young, Bala, Ruddha, both are considered as difficult management. Whereas in the Chikitsa, it's mentioned as Sukara. This again is not a controversy, rather it's the way you look at it. The time taken for the union is lesser in younger age, and hence it is considered Sukara. Whereas as the treatment of fracture requires an active cooperation and a prolonged immobilization, in a child it will be difficult to maintain that. Naturally, child may not cooperate well, and hence it is considered as the Dustara in case of the younger age. So that has to be understood in a different manner. Now, as far as the current physiology is concerned, the changes which occur in the bone during the age, the impact of the age on the bone metabolism is in the younger age up to the age of around 20 or 21 plus. The bone growth is rapid, and there is the bone deposition of the calcium as well as the peak bone mass also is enhancing regularly. After the age of 21 up to the age of maybe 50, the growth rate of the bone mass as well as the capacity of the bone to develop or modify, remodeling of the bone is steady. It doesn't remain the same as it. And naturally, after the age of 50, it gets reduced, and the osteoporosis tends to occur as a consequent effect of the age. Of course, if there are some triggering factors which can enhance this osteoporosis, this becomes more rapid. If the patient has maintained healthy food and lifestyle choices, then again this can be slowed down. This is about the basic physiology of the bone, and depending upon the age, the changes which would occur. Now, in a case of fracture union, this would have a significant impact. As the capacity of the bone to remodel is more in the younger age, the union would occur rapidly, and in the later age, because there is a natural tendency for the osteoporosis, the time taken for the union would be lesser, and that's exactly what Sushruta has mentioned. Now, the next step of the principle of the fracture management is the reduction. Reduction is a basic issue, and the reduction procedure is just to reverse the changes which have occurred in the injury. So, to know that, you have to know exactly how the injury has occurred. In the present orthopedics discipline, we classify the fractures into two categories: the fracture produced due to the direct trauma and the fractures produced due to the indirect trauma. Fractures produced due to the direct trauma, there the displacement which has occurred would always depending upon the direction of the impact and the momentum. So it's unpredictable. Only when you reenact the scene of the fracture, like how the fracture has occurred, how the patient has fallen, what are the forces acting on the area, if you know that, then only you can predict the deformity. Of course, now with the imaging studies like X-rays, scanning, you can have a three-dimensional image of the fracture and the deformity can be assessed accurately, but still this impact, the direction of the impact has a role to play. And the mechanism of reduction of the fracture would involve reversing these forces. So that's the idea. Whereas if a fracture is produced due to the indirect trauma, the force which acts upon the area of the fracture would be the muscles, and depending upon the strength of the muscles and the alignment of the muscles, the displacement could be predictable. You know exactly like how the displacement would occur. Like in case of a Colles fracture, there would be a proximal displacement. In case of the fracture of the neck of the femur, it will be an abduction as such. That's the position depending upon the muscles. Where the deformity is predictable and the reduction technique can be written down, like you have to do the reduction this way as such. Whereas in other conditions, the reduction procedure has to be customized depending upon the patient's condition. So that's the basic issue, and that's what exactly Sushil has mentioned, like avanamitam unnashet unnatam cha avapidayet anchet atikshiptam adhogatam cha uparivartayet. The reduction procedure would be if there is a depressed bone after the fracture, that needs to be elevated. If the bone piece is elevated, that needs to be depressed or pushed down. If there is a proximal displacement, then that has to be corrected with the traction. Anchana is the traction. Or if there is actually a gap is increased, if there is a fracture with a wide gap there, then that condition has to be reduced by bringing the bone pieces together. And this is exactly how the correction has to be done. And the whole protocol is Anchanehi Pidaneshtiva Samshepehi Bandhanestada Sandhin Sharire Sarvamstu Chalanapi Achalanapi Etistu Stapanopayehi Stapayet Matiman Bhiraka. That protocol of the whole management of the fracture is what called as Bhagnachikitsa upaya. Bhagnachikitsa upaya. The techniques of management are Anchana, that is the traction, Pidana, the local manipulation, Samshepana, ultimately it results in the reduction. So once the reduction has occurred, then the next is Bandhana, immobilization till the union has occurred, and that is the total course of the treatment. In the current orthopedics also it is exactly the same. The management principles are the reduction either could be by a closed reduction or open reduction. Now you have another alternative as open reduction, where you may make use of a surgical incision and then directly handle the bone. And then of course the immobilization is a 3M tool, and there is another component, that's the rehabilitation. Rehabilitation is attempting or helping the patient to regain the normal functions and normal activities by maybe exercises or physiotherapy as such. The present current treatment, orthopedic surgery, it has treatment goals are for either to prevent the infection, and another of the goal, in addition to these basic techniques of the fracture management, the other goals are to prevent the infection and allow the fracture to heal. To allow the fracture to heal, you have to have reduction and immobilization, and restore the function in the injured limb by the rehabilitation. And the basic principles otherwise in case of a fracture management would be the additional, beyond what we call as immobilization and rehabilitation, reduction, immobilization, rehabilitation, these are the basic functions of the orthopedic discipline. In addition to that, the other factors which you need to consider would be vital support. If a patient has an injury and if a patient is brought to you immediate after the injury, you have to ensure that the injury has not affected the vitality of the patient, depending upon the location or depending upon the intensity of the trauma or the other complications like bleeding and so on. So they need to be taken care of. So if the patient has hypovolemia due to the loss of blood, that has to be taken care of. If a fracture of the skull has resulted in injury to the brain, that needs to be taken care of. So that's what we call by the vital support. And it may require multidisciplinary approach. So it's not the bone alone which need to be considered. The complications that could be produced due to the fracture have to be managed, and there you need to have a priority. Prioritization is necessary. Like if there is a injury to the brain, naturally priority would be to the treatment of the brain than really the fracture, the bone injury. Or suppose if there is treatment fracture penetration in the lungs and then there is a leakage of the air into from the lungs in a rib fracture, the priority would be to maintain the ventilation than the other way. So that's another of the issue, which is one of the basic issue of the orthopedic discipline now, which Sushila has not specifically mentioned, but it is understood. And then of course every patient of fracture will have a pain, and pain management is considered as one of the critical issues in case of the fracture management. And the patient may have other morbidities, comorbidities. As I said about the comorbidities like maybe injury to the muscles, injury to the other vital organs like liver or so on. And there again the issue is about the prioritization as well as the management. Now as far as the immobilization techniques are concerned, Churchill has described the immobilization only with a splint. The basic idea of the traction and the other techniques also are detailed when we go into the further description of the individual fractures. So there again we refer to that issue. But when it comes to the general principle, Sushila has mentioned about the immobilization with the splints only, but the other techniques also were known. Whereas in the current situation, we classify the immobilization techniques as the castings, that is the splintings. Splints would be either slings, crepe bandages, or actually the splint like POP or fiberglass and so on, which keep the immobilization depending upon the degree of the immobilization required. Either it could be a sling where some mobilization is allowed, crepe bandages where again the mobilization is allowed, not to the same extent as that of the slings, and the splints they would always produce rigidity. And then the other part is the dynamic splinting, which we have already referred to. Then the other is the traction. Traction is pulling apart, and traction again now we have either skin traction or skeletal traction or the external fixation. Skin traction is where you put a elastic bandage and put a weight over the area. The advantages of the skin traction is it's a very simple procedure and comparatively painless. Complications are less. But the disadvantages of the skin traction are major. The amount of the weight which you can put in would be lesser. Traction is required when there is a constant muscle activity which keeps the bones displaced. If the muscle activity is producing a displacement of the bone, a simple immobilization of the splint may not be possible, may not be enough, because the splint would be giving only external support, and a continuous muscle activity would be effective. So those are rather in a very general sense, those areas where the muscles are stronger, like the thighs and the knee, these areas, a continuous traction may be required. A general principle, of course, it depends further more details. I am just using very simplest possible explanation of the requirement of the traction. And with the skin traction, the maximum weight which you can put in would be around 5 kgs. Beyond 5 kgs, the skin cannot tolerate the weight. And the amount of the force or the weight acting upon the site of the fracture, when you use a skin traction, will be much lesser, because the weight which you have placed over this skin traction would be utilized by the other soft tissues, the muscles and the other soft tissues, skin and adipose tissue, all that would be taken, making use of that, or they would be affected by the weight. So net weight which is acting upon the fracture area would be much lesser and unpredictable. It also depends upon the size of the patient, the thickness of the fat tissue and so on. And moreover, the direction of the force which you can manage with the skin traction would not be very accurate, cannot be very accurate to correct the fracture displacement. So in certain cases where these factors can be otherwise utilized, you may prefer a skin traction because it is convenient. The other way is the skeletal traction. In the skeletal traction, the technique is you have to drive a nail across the bone and then put a traction. Weight is connected to that. With this, the advantages are the amount of the force which is acting upon the area is exactly the same. If you put 5 kg weight, all the 5 kg weight will be acting upon the bone. That's an advantage. And hence, the reduction traction would be very accurate. Moreover, in many, the direction of the force also can be easily modified. Direction of the force can be easily modified by putting a wheel over the area somewhere above, and the whole direction of this weight can be modified easily. If there is a need, you may use more than one nail, maybe on the proximal as well as the distal side. We'll see some examples of that. And hence the directions of the force can be still more advantageous, modified. That's the advantage. But the disadvantage of the skeletal traction is that because it is an invasive procedure, the complications of sepsis and others are also more. And when you drive the nail, you need to take care of the bone. That driving the nail across the bone also can harm the bone. So you cannot just use it in every bone. So only in specified conditions where the driving the nail would not affect the bone, in such conditions the nail could be driven, and the patient cannot move at all. It would be permanently immobilizing the bone or continuously immobilizing the bone till the union has occurred. So these are the disadvantages, and maintenance of that also is a difficult issue. Now another alternative which is now becoming more popular instead of this continuous skeletal traction is a skeletal traction with the external fixation, which is also called as Elizaro's technique. Now these days this technique is becoming more popular. In that Elizaro's technique or the external fixation technique, the nails are driven across the area of the fracture on the proximal as well as distal side, and these nails are connected with a rod outside the body, and this length of this or the gap between the two rods can be just increased or reduced with a hinge mechanism continuously depending upon the need. So every day it can be managed so that as the fracture unites, as the fracture is healing, gradually can modify. You have that dynamic set also, and the patient can bear the weight quite early with the rod because the rod itself will be carrying the weight of the body. The external fixation now is becoming more popular in many of the conditions. So as far as the traction techniques are concerned, now you have mainly 3 techniques: skin, skeletal and external fixation. Sushruta also has described about the traction. I will come to that part when we discuss about the individual fractures later on. Then the other now would be the surgical interventions. Surgical interventions are required where the close reduction is not possible, which is also called as the open reduction procedure. And the technique could be either simply opening the area and then trying to reduce the fracture by a direct intervention, direct handling of the bone, and then closing the wound. That's where no other supporting measures may be used. Or it could be wires, screws or plates, etc. Or intramedullary nails, where a nail is driven across the bone and that nail is placed across the fractured area. Or prosthesis, a artificial structure to replace the bone, remove the bone, and these are the possible options of surgical interventions available now. Of course, in Sushruta's period, this was not really available. Now, once the immobilization has occurred, the next part is उत्पिष्टम अथमिष्टलिष्टम संधिम वैद्यो न घटयेत तस्य शीतान् परिशेकान् प्रदेहांश्च अपचारयेत अभिघाते हृते सन्धि स्वाम्यादि प्रकृतिं पुनः घृतदिग्धेन पट्टेन वेष्टयित्वा यथाविधि पट्टोपरि कुशां दत्वा यथावत् बन्धमाचरेत. Once the immobilization has occurred, till the union has occurred, there should be no movement. Attempts to immobilization may not be required in case of a utpishta and vishlishta badana, compression fractures, where there is no displacement. In that condition, you may not attempt for reduction, you just keep the bones as such and then immobilize. Immobilization with the same bandages and Shisa Parisheka can be given. If there is a dislocation of the joint, in that condition, the joint has to be again reduced, reduction of the joint has to be done, and you take Kristadikdhena Pattena, no need of rigid splinting. Instead, a cloth which is dipped in a ghee, something like the crepe bandit. It gives some elasticity and then reduces the resistance, is used, and then over that cushions are placed. If there is a need, the splint could be used as such. That's about the general principles of fracture management. The next comes in the individual fractures. The pratyanga bhagnam vidhi, pratyanga bhagnasya vidhi atha gurbham pravakshate. The individual fractures and their management principles are described in Sushruta. I think we will continue it in the next session. So next session we will continue these individual fractures because already it's all the time now. And if there are any questions, we will try to answer and then wind up. Right, there are no questions. So we will wind up today. We will continue in the next session.